Welcome back. This is episode 2 of Functional Neurosurgery Explained. In episode 1, we asked, where are we in the brain? Today, we ask a different question. How do we fix brain space so we can navigate through it accurately? This episode is all about stereotactic frames, what they are, why they exist, and how they help us reach a small, deep target inside the brain. Let's dive in. Before we can target anything inside the brain, we need to solve one fundamental problem. How do we make brain space stable and measurable? Think about it. The patient breathes. The brain moves slightly. Even small movements during surgery can shift your target by 1 or 2 millimeters. And in functional neurosurgery, that is the difference between a good outcome and a side effect. Stereotactic frames were created to solve exactly this. They do 3 things. They eliminate head movement completely. They define a reference space that stays the same throughout the whole procedure. And they link your imaging, your planning, and your surgery into one consistent system. Without this step, precision is just a theory. Frames make it real. Let me take you back to where this all truly began. In 1908, 2 scientists named Horsley and Clarke invented stereotaxis. Their original goal was simple: to create a way to make lesions in the brain that were accurate in position, limited in size, and causing as little damage as possible to surrounding structures. They even invented the word stereotaxic, from 2 Greek words, stereos meaning solid, and taxis meaning arrangement. Their device was designed for animals, but the idea was revolutionary. They said by this method, every cubic millimeter of the brain could be studied. This concept was then adapted for human surgery by Spiegel and Weisses in 1947. These early frames used polar coordinates, meaning angles and depth, to define the trajectory. That was the beginning, and everything we use today is built on this same foundation. The CRW frame, named after Cosman, Roberts, and Wells, is one of the most widely used stereotactic systems in DBS. Now, here is something important to understand correctly. CRW is not a purely Cartesian system for the trajectory. It is what we call an arc radius system. What is uniquely Cartesian about the CRW is its phantom target system. This is a physical safety check device. Before the frame goes on the patient's head, you place a pointer on the phantom that mimics the target. It catches human error before you even enter the operating room. The zero reference point of the CRW frame sits at the center of the frame itself. This combination of arc radius geometry and the physical safety check makes the CRW a reliable and auditable system. Now let's talk about the Leksell frame. And here is the most important thing to understand first. Both Leksell and CRW are arc radius systems. They both use arc and ring angles to define the trajectory. In both frames, the target can be approached from any direction, as long as the target coordinates and depth stay fixed. So what is actually different between them? The first difference is the zero reference point. In CRW, the zero is at the center of the frame. In Leksell, the zero sits at the upper posterior right corner. The other difference is that CRW uses a Cartesian phantom as a physical safety check, which Leksell does not use in the same way. The modern version of the system is called the Leksell Vantage, which keeps the same arc-centered principle with updated engineering. Let me ask you something. If you are planning a DBS electrode to the subthalamic nucleus and you realize the first trajectory you chose passes through a blood vessel, what do you do? With an arc radius system, the answer is simple. Change the entry point. Adjust the arc and ring angles. The target coordinates and depth stay exactly the same. This is the key principle. In arc radius frames like CRW and Leksell, the target can be reached from any trajectory as long as the target coordinates and depth remain fixed. By keeping the target fixed at the center of the arc, you minimize error exactly where it matters most. Now let's talk about a newer approach, robotic stereotactic systems. The goal is exactly the same as frames. Accurate, reproducible targeting in three-dimensional space. But instead of a mechanical arc, robots use computer-controlled positioning to reproduce your planned trajectory. The workflow is straightforward. You define the target on imaging, the robot positions itself with high mechanical precision and holds that position for the surgeon. One area where robots are particularly useful is for procedures that require many different trajectories to many different targets at the same time. A good example of this is SEEG, or stereoelectroencephalography for epilepsy surgery. We'll cover that in a future episode. What about frameless systems? Can we skip the frame entirely? In many neurosurgical procedures, yes. Frameless navigation works very well. They are less invasive, faster to set up, and for some patients, much less intimidating than having a metal frame bolted to their head. But here's the key question. For deep brain stimulation, where 1 millimeter matters, are they accurate enough? The honest answer is that for most DBS procedures today, frames remain the reference standard. The second part of the key message is about improvement. Even if you have perfect knowledge and the best equipment, you still need to ask after every case. Did we actually hit the target we planned? This is called auditing your outcomes, comparing the intended target with the actual electrode position on the post-operative scan. Most centers that are excellent at DBS do this routinely. They track their accuracy, they find their errors, and they adjust their workflow to improve. A consistent, reproducible workflow, combined with honest and regular audit of your results, is what separates good functional neurosurgeon from great one. The second part of the key message is about improvement. Even if you have perfect knowledge and the best equipment, you still need to ask after every case. Did we actually hit the target we planned? This is called auditing your outcomes. Comparing the intended target with the actual electrode position on the post-operative scan. Most centers that are excellent at DBS do this routinely. They track their accuracy, they find their errors, and they adjust their workflow to improve. A consistent, reproducible workflow combined with honest and regular audit of your results is what separates good functional neurosurgery from great functional neurosurgery. So let's look at where we are in this series. Episode 1 answered the question, where are we in the brain? That was about localization. Episode 2 answered, how do we get there accurately? That was about frames, geometry, and precision. Now comes the question that gets to the heart of functional neurosurgery. Once we arrive at the target, what do we actually do? Do we modulate the circuit or do we destroy it? Episode 3 will answer this, neuromodulation versus neuroablation. I'll see you there.